Hello. Hi everyone. Very good evening and thank you for the First Cure Health to organize this online event. This event is regarding the proctology problems related to the piles, anal fissure and anal fistula. And to all the audience, this is a good evening from my side and I am Dr. Rakesh Durkhure. I'm a proctologist. I'm a laparoscopic, abdominal cancers, and the bariatric surgeon as well. And I have been practicing into these fields for last 22 years. So we will be presenting and going through our presentation regarding all the proctology cases. Is my slides very much visible to you guys? Hello, is it very much visible?
Yes, sir, they're visible. Carry on.
So in the very start, I would like to show you the basic anatomy of the anal canal and the rectum. Rectum is the distalmost part which ends up into the anal canal. So you see the S-shaped zigzag rectal ampulla in which stools of ours rest here till they gain a momentum, and by a vis ergo, that means by a push from behind, then it gives us a feeling that we have to pass out our stools. In regard to this, in the center part, as you can see with my arrow, that there is a rectal ampulla in the center. Onto the sides, brown color are the muscles, in which the most outer one and the stout and bigger ones are called as the external sphincters. And inside of it is the internal sphincters.
Hi. Can we project the PPT, please, and resume? So you're on mute. Yeah, great.
Hi all. Sorry for the disruption. Here, we are sleeping. What activity external space. So that's what it is. So internal sphincters which keep it closed.
So
We
sorry to
are
interrupt,
sleeping.
but there's a lag at your end. We're not able to hear you clearly. There's some lag at your end.
बेटर आता है इंटरनेट कनेक्शन बेटर आता है किसी कंपनी
Hi, is it audible?
Yes, you're audible, but we cannot see you.
Okay, just a second.
Yes, sir, we can go on. Yes, sir.
Okay.
Can do. Yeah.
So should we start from the very start, or we can continue from the place?
So we can start from this slide itself.
Okay, so this was the slide where I was telling you about the anatomy of our back passage, which says that there are internal sphincters, the small thin brown lines that you see in the inside, and outer ones are the stout, more muscular external sphincters. And inside it is the internal, and further inside is the blue color dot, which represents the hemorrhoids. And then comes the internal rectum. Okay, so this what is the mainly our anatomy of our back passage. Next slide. Screen पर touch करेगा ना? Screen पर आएगा ना ये? So, what are the common perianal defecatory symptoms with which the patient will come to you? Okay, so mostly they are the number one, pain during defecation. Patient involuntarily we pass our poop in the morning without any most common symptom is the pain. When you start feeling that there is something wrong going on. So number one is the pain. Number two is the constipation. Connection is unstable. So number two is the constipation. If the patient is having constipation, if you are having a hard stools, there is something which can happen to you. Next is the bleeding, which can happen before or after passing of the stool. Or then there is a constant pain for few 3, 4, 5, 6 hours, maybe half of the day after passage of the stool. So these are the common thing. Patient may say that, I'm still feeling some kind of itching sensation around that, or some pus discharge from the side of the back passages, or they can think that there is something which is coming out from the back passage. They feel something, some kind of these kinds of the dangling skin tags, which they feel while washing their bottoms. So these are the very common symptoms. And again, in the hemorrhoids, let's come to the, so our talk involves the three basic diseases which constitutes 99% of the problems related to our back passage. That is number one, hemorrhoids or the piles. In our local language, we call it a Bawaseer. Next comes the fistula or the bhagandar, and third is the fissure. So first, I would like to talk and share our points with you regarding the hemorrhoids, the piles. In this, the most common symptoms is the bleeding, the painless bleeding. At the end of your action in the morning, you see that there is some drop of blood in your toilet pan seat. So you don't realize when did it happen. But yes, it happened. So the painless bleeding is the most common problem that we see. It is usually associated with the constipation. Patient do recall, yes, I was having a little bit constipation and I passed blood. Or there can be at the end of the stool, there can be blood. Because the stool has gone through the back passage, it has rubbed the inner lining. When the stool has come out, then the drop of blood comes out. That is called as hemorrhoids, most commonly. Now they are generally of the two types, internal one, external one, or the interno-external. So as the name suggests, internal is the one that you cannot feel. External is the one that is very much visible. And then third is the interno-external. That means it is an extension from inside to the outside. So let's read a little bit about what is the grade of the hemorrhoids for the patients which comes to you. Now, if you see, there are the 4 grades of the hemorrhoids. First one is there is no prolapse, just the prominent vessel, and the patient complains of the something or the other thing, like here. So these is called as the internal hemorrhoids with the grade 1, very smaller ones. Then comes the grade 2 hemorrhoids. In this grade 2 hemorrhoids, what happens? It comes out sometimes when we strain, it comes out, but before we could notice it, that is it actually out, it goes back inside and may present with little bit of the bleeding as well. So now comes the grade 3, where the surgical intervention is 100% required. If the bleeding is too much, even in the grade 2, then again I insist that the surgery is required, or you need to seek attention by a surgeon or a proctologist. Now in the third grade, there is a prolapse with the strain and it has to be pushed back in. That is called the third grade. It has come out, but somehow you have to push it back. Then only it will go in, and then only you get a relief, or else it becomes a painful job for you. So that is the third grade of the hemorrhoids. And then comes the fourth grade, where, or we call it as an interno-external, where it has come out and how much ever you try to push it back inside, it is not going to go in. So these are the 1, 2, 3, 4 grades of a hemorrhoids. Now, if we look into the etiopathogenesis of the hemorrhoids, why did it actually happen? What started? This is the most common question that a patient comes up with when he or she comes up with these kinds of the symptoms. Why did it happen? But they don't recall that what led to this thing. They say we are having bleeding, but if you keep on asking them, they say yes. What is your diet pattern? Oh yes, I have been straining a lot and I'm constipated. Why? Because my diet is low in fiber. I'm a fast food lover, and I keep on partying, and I'm a very much busy lifestyle, and I drink less amount of the water. My fluid intake is almost nil. Only when someone asks for a water, I recall that yes, I too want a water, or else I quench my thirst just with a cup of tea or coffee rather than having a water. So low fiber diet leads to the less bulky stool. Less bulky stool, you have to push the hard ball. It is like an iron ball you're playing a football with. It is not a soft ball. So more you strain during the defecation act, it increases the pressure inside our sigmoid colon or the rectum. Then when it pushes back inside, so these are the veins. These are soft. Hemorrhoid is a vein which everyone have it at a 3, 7, and 11 o'clock position, which I will tell you, okay, at the time of the fistula. So now when it pushes too much, the arteries are thicker and veins are thin walled. So venous return back inside, it reduces. So veins becomes engorged. When they become engorged and when the hard stool passes through it, it breaks all the channels of the dam, and then the bleeding happens. So that's what is the hemorrhoids happens. Let's talk about the conservative management of the hemorrhoids. I don't usually go ahead with the surgical part in the back passage thing, because conservative management is the best treatment. Why? Because this is a lifestyle disease, and if you change your lifestyle, the way you eat and drink, the treatment is almost done just by that. A very simple line, I have read it and heard it, and I always insist to write it onto my patients' OPD paper, is that your greens should be more than the grains. Have more of the water intake, should be as much as you can. Juices as much as you can. Fiber rich diet should be good. Good amount of the laxatives. I'm not saying that you eat the laxative or keep on having it, but yes, if you're having a problem, first resolve the problem with the laxative and gradually wean off from the laxative uses. because these are not the use, it leads to the abuse of it. And have more and more of the salads, green leafy vegetables, the green salads, and if required, give the medications and the flavonoids that we use generally for the treating of the hemorrhoids. So again, coming back to the first point, green should be more than grains. Chapati, rice should be as low as we can, and then the plant-based diet is the best diet that a human being can have. Now, if it does not resolve, or if the bleeding is too much, what do we do now? Then we get on to our second part, like the surgical part of the hemorrhoids. There are certain ways that we do it. Number one of it is the stapler hemorrhoid. Okay, very common, very nice surgical thing. Next is the laser ablation. By the laser, we ablate, we burn the hemorrhoids. Laser is a, if you see the full form, it is a light amplification by stimulated emission of radiation. So it burns the piles, the hemorrhoids. So they shrink and the passage increases. It is something like a checkpost of a policeman, which we will tell you more in the Fissure. How the traffic is going to move fast. You remove the barricades and the traffic streamlines one car behind the other. Then only the traffic is streamlined. If the checkpost is too tight and then everyone is trying to jump, there will be a chaos. So that's why the laser ablation, it shrinks the pile, or the conventional method like the Milligan-Morgan that we do by the open technique, and then we suture with the dissolving sutures, all the bases of the hemorrhoids and everything. If they are too much hanging out, then the ring application is another surgical method, but generally nowadays no one uses it because it leads to a lot of pain and people wants to go back to their job and work within a day or two. The next is the injection sclerotherapy. We put in a 5% phenol in almond oil or the arachis oil. So this leads again to the fibrosis. Our job is to shrink or fibrose or cut or coagulate or remove the hemorrhoids, and their bases should be tied off very nicely and securely. So these are the surgical treatment. Let's go on to each of the surgical treatment in a very short way. You see in the first picture A, this is the hemorrhoidal gun that we have put it in. We take a persistent suture and we take away all kind of the hemorrhoids. So we are not attacking onto the external hemorrhoid or the internal hemorrhoid. Rather, we are going directly up to the base of the hemorrhoid, which is a line, stapled line in the picture B, about a nice curvilinear line. So these valves are called as the anal valve or the dentate line, the white color. This one is white color. So we go much above it. So it's a painless procedure. This is called as a stapler hemorrhoid. Now again, this is the laser treatment of the hemorrhoids. The purple one is the internal hemorrhoids, and the bluish one, or the bluish color berries, are the external hemorrhoids. We put our laser fiber into the internal hemorrhoids and we burn them out completely. That's what is the laser treatment. Again, there is no cut, no injury, but as we are burning directly onto it, it is very slightly more painful than the stapler hemorrhoid. But again, we call it as a painless treatment of the hemorrhoids. And it is very much common because it is a daycare procedure. There is hardly any cut which is there, and it's very less painful. Now, that was the treatment about the hemorrhoids and the thing. Now we come on to the fissures. What is a Fissure-in Ano? Fissure is kind of a crack in the wall of our back passage. Along with that, there is a sentinel pile, extra skin tag which hangs out of it. So that is called as a Fissure-in Ano. So it is a longitudinal tear in the anal canal. Mostly it happens into the posterior midline, behind your back passage, towards the spinal region of the back passage, too near to the spine. So that is called, we call it posterior midline. 90% is that area, 10% is anteriorly. And what are the causes which leads to the Fissure-in Ano? They are, when we are passing out a hard stool, then yes, it again, as I told you, it rubs through the inner lining of the back passage and leads to the bleeding. So it stimulates the muscles, the brown color things which I shown you in the very first slide, they contract. When they contract, less is the passage, harder is the stool, which require more passage to pass down. So there is more of a friction. More is the friction, more injury. More injury, more contraction of the muscle. More contraction of the muscle will lead to more tightening of the passage. And again, there is a constipation. So it's a vicious circle in which we are stuck. So we have to break it. So we open up the passage, make the stool soft, then your fissure gets healed up. Or sometimes it also happens when because of the overuse of the back passage, which happens when we are actually going through our diarrhea. And sometimes in the females, mostly when there is a delivery. In the females, it is into the anterior midline, which happens, or posterior midline in the mostly in the males. What are the signs of anal anal fissure in ano? As you see into the picture, there is a crack in the midline. This is called as the anal fissure, and under it is the skin tag, a small protrusion of the skin from the back passage, which never goes back inside, is called as the sentinel pile. It is not the hemorrhoidal pile. As I told you before, while we were discussing about the hemorrhoids, that the hemorrhoids things, it goes back inside in stage 2, or we have to push it back in stage 3. But here, whatever is the stage of the fissure, it always remains outside. So that is a differentiating feature between the hemorrhoids and the fissure piles. So there is a severe acute pain while passing the stool. In our old books of the surgery, it is written that the patient goes to the toilet with couple of beer in the hand, so as to. So that is a problem. Now, earbuds आपने शायद open close करा होगा. It is fine. I think. Okay. So now, what are the signs? Number one, I told you that there is a severe acute pain. Next is there is a blood over stool. What is the meaning of blood over stool? That when the hard stool comes through it, it comes out very slowly. In that process, the small amount of the bleeding happens and the blood comes onto the stool as a streak onto one side, mostly onto the posterior side. Or sometimes it is just the blood not associated with the stool as such. Or sometimes maybe just the mucus discharge, the stool does not come out and leads to too much of the itching, pain, sensation. The itching persists for many hours still after passage of the stool, washing of the thing, applying of the ointment, and of course the constipation, which is the mother root cause of all kind of the anal problems, that is also there. Sentinel pylori tag or some kind of the ulcer may suggest that patient is having a fissure. I think this was let's say treatment only. So in the fissure thing, I must tell you what are the treatment. Now in the treatment part of the fissure, 95 to 99% of the anal fissures, they are treated very much conservatively, just by the medication, SEDS bath, more of the fibers, laxatives, and one kind of the ointment which I prescribe giving to the patient is the lidocaine ointment, which also should contain the glycerin. That is must as a part because GTN actually acts locally to relieve the contraction pressure of our perianal muscles. So only by these methods it can be done. If ever your all kind of the medical things they fail, then what is the next treatment plan? It is the surgical plan. We do the anal fissurectomy. We cut the fissure. Fissure means the internal sphincters, or we do the anal dilatation. It can either be done by the laser or by the open technique. See. So, so now let's come to the last portion of our talk, which is the Fistula-in Ano. That means an extra passage. What is the Fistula-in Ano? So Fistula-in Ano actually is a chronic condition in which there is an abnormal connection between the outside skin and the inside rectum or the anal canal, and which is lined up by the granulation tissue. That means it is a full-fledged pipe, extra kind of a connection from the, if this is the back passage, from the side of it forms up another kind of the tract here. So that is another tract. This is called as the Fistula-in Ano. Now, for that thing, what leads to the Fistula-in Ano formation? If there is some kind of the infection into the glands. What is the gland? Gland is a hair follicle gland. So, which we call this as a muhase kind of thing over there, or any kind of a ball throw. So there is an infection which happens into the gland, which leads to little bit of the abscess formation. In that abscess, it ruptures onto the both ways, outside onto the skin, inside onto the anal canal. So outside, inside, when there becomes an infection, then it opens up like this. This leads to the fistula formation. And patient will come to your OPD or the clinic with the complaint of the intermittent pus discharge. Sir, it is healed up. No, sir, it has again come back. Sir, with antibiotic it heals up. No, sir, it is again come back. So they are troubled, coming and going, coming and going. Finally, then you realize, excluding whether the patient is having Crohn's disease or any other problem, we just do the finger checkup, clinical examination, that there is one opening, two opening, three opening, how much is the pus, and by feeling or to the perianal skin, that is the tissue is hard enough, like a tubular or something like that, that leads to the formation of this thing. Or there is a pain rectally whenever they pass a stool. Or if the fistula is very small, patient may tell you that they are experiencing pus coming from the back passage only. Now, these are the different type of the fistulas that you see over here. Broadly, for the patient, it is either high fistula or low fistula. What decides high and low is the dentate line, the white line. So anything which is very close by, as in the first one from the bottom, it is the submucosal, very small one, we call it as a submucosal fistula. Then comes the intersphincteric, that means the second blue line. So in the second blue line, it goes in between the two fistula tracts like this and then enter into the back passage. Third one is transsphincteric, through the sphincters. These are the ones which are tough to deal with, because here onwards, like the transsphincteric, suprasphincteric, and extrasphincteric. What happens that there are very high chances of the injury to the sphincter, the back passage, when we are going to operate over here. So these are the, but for the sake of the patient, high fistula or low fistula, that's it. Now, as I was telling it to you that like the sundial or like the dial of our watch, we decide about how a fistula is to be diagnosed. Very common problem in India, very common problem. But then very less learned about this disease by any of the colleagues, friends, junior fellows, or the surgeons, and what is to diagnose, how to diagnose. Number one is the clinically, as I told you, that there is a pus discharging sinus or the opening, then there is a thick tissue intervening, and then there is a back passage. So that is a clinical examination. But your fingers does not have a 3D mapping of that back passage area. That is how the role of MRI comes in. But in between comes the FISTULOGRAM, which I wish that this technique should die out. because it also does not gives you a 3D vision of a fistula. Like in the last image that you see, it is a X-ray. That means the fixed fistulogram. It is only the two-way fistula, the 2D image. So we cannot see to it. But in this MRI, it gives you a three-dimensional. Topmost is the 12 o'clock, 12, 6, and then right is 3, left is 9. And then, of course, it is something like the dial of your watch that you can say that it is extending from 3 o'clock to 2 o'clock and then going inside. And in the sagittal planes, like over here in the second image, you can see that it is the big cavity onto the right hand side and the smaller one onto the left hand side. And then this is the back passage, the scrotal area of the patient, and then from behind it is connected to the opposite side. We call it as a horseshoe kind of a fistula. So these are the connected fistulas. What all are the treatment of a fistulas? So number one is the fistulectomy or the fistulotomy. Well, it is a very common terms, but they have got a different relevance. Fistulotomy is we probe the fistula, lay it open. And fistulectomy is we cannot cut the bridge of the skin, we have to remove the tract. Fistulotomy is if this is a fistula, you lay it open. It becomes fistulotomy. Fistulectomy is something like this. You have to remove the whole of the tract, leaving the back passage intact. Then there is a set on. We put in a thread from here to there. This can be a simple thread. This can be any kind of metallic wire which people used to use it, or the proline suture, or the latex kind of a feeding tube, or any other kind of a very thin tube can be used. Or it can be a shar. Shar means a shar sutra. If it is a too complicated, too big, we use a flap. Most healthiest of the skin, tissue, everything comes from other foreign area, and then that means the other part of the body, and then gets planted there. This is called as the flap surgery. Or we can fill in with the fibrin glue, the fistula tract, and it seals. But the result of the glue is not very good. Result of the flap is not very good because these are the remote thing. What is best is the fistulectomy, removal of the tract, or if it is complicated, then use the set-on. Last but not the least is the WAFT, video assisted anal fistula treatment, the WAFT treatment. We do it by the laser, but we go and probe all kind of the tract, fistula tract, wherever it is going right, left, right, up or down, or higher up. We go with the help of the 8-degree telescope, and then along with that, there is an operating channel. Keep on going on, keep on clearing the fistula tract, and then with the help of our laser fiber, we keep burning all of this tract. So like in this first picture, there is a small abscess, very first one, it is normal. Then what is they are showing over here in the box is that the abscess has formed with the opening outside and opening inside. So this is a fistula. And then here it is shown as the set-on ring. This is the fistula. And in this one, we have passed on a yellow color set-on. This is the yellow color set-on. And then we have tied it off. And we keep on tightening it. It's like kind of a, wire saw in a cheese form. So it keeps on cutting through it, and the muscles will keep on healing up. So this is the technique that we use in the very complex kind of the fistulas. These are the local Shar Sutra kind of the thing with a needle, help of the needle, a needle in which there is an eye in the end, or a fistula probe. So you pass on the probe through the fistula, and then you pass on the Shar Sutra along with dipped into the Shar Sutra material. That means an irritant. And gradually you keep on doing it. It is not a bad, it's a very good procedure, but only if you know how to do it. So these are the basic treatment modalities of the fistula. Here I rest all my things, and I'm open to all kind of the questions for which I would love to answer. In the chat box. All right. So now there is a question which has come up to me, which says that, sir, I have heard a lot about the Shara Sutra method, the laser surgery. Which one is better, the Shara Sutra one or the laser surgery? I must say that if there is a multiple opening, always get an MRI done. If there is a multiple opening, then one should go ahead with the Shar Sutra. If it is a redo kind of a surgery, go ahead with the Shar Sutra and do it. But if it is a simple, straight, a small tract, everything is notified, and even if it is a 2 or 3 tracts, we can do it by the laser, but it should not be complicated. Like means it should not be over and above the dentate line. It should not be supralevator or extra sphincteric. It should be either transsphincteric or intrasphincteric or the mucosal one. That for that thing, laser is good, but for other thing, the Shar Sutra is good. All right. What are the chances of recurrence after laser surgery? Along with that, the recovery time of laser or stapler surgery. Sir, I must tell you, Mr. Nikhil, that the chances of recurrence totally depends onto your lifestyle again, because the fistula happened to you with the constipation. Now, if the constipation persists, then again there are higher the chances that you might get it back in the life. But if your surgeon has removed it properly, the complete fistula, and whether it is by the laser or by the fistulectomy method, if they have done the proper job to you, it usually does not recurs. But the book says from 30 to 40% of the chances it might come back. In my book, I say that hardly 5%, hardly, very hardly 5% of the fistulas they have come back. And I remember their names too. So if I remember the name, that means yes, I have got a very less fistula recurrence rate. About the recovery time of the laser and stapler, yes, for the laser thing, recovery time is less because less cutting, less trauma, no bleeding almost, and then we just burn the tissues. So as compared to the stapler thing, the laser thing is very good. Okay, so next is I do not experience any pain, but I have occasional blood with a stool. What is the next step? This question of yours, Mr. Nikhil, is directing into the direction of the hemorrhoids, the piles. There is no pain, nothing, but occasionally, sometimes you have had something which is not good for your tummy and not good for your colon and the rectum. That means it is leading to the constipation. Little bit constipation is all right, but sometimes, it hurts a little bit and then leads to the bleeding. So what you are having is a hemorrhoids. You should seek the help of a proctologist, where they will be doing the internal examination with the proctoscope and by finger, and will assess that what is the best treatment. A conservative, surgical, if surgical, then by the laser or a what if diet and exercise is there and still you experience constipation? Sir, exercise is different thing, diet is a different thing. So exercise is not a good thing to discuss over here, because exercise, with the exercise you lose a lot of water, and then if you're not drinking or compensating water intake which you have lost during the exercises, then you will lead to it will lead to the constipation. Diet should be green more than grain. I reiterate, I rephrase it, that it should always be more than the grains. If that is there, you won't have any kind of constipation, and thus any kind of recurrence won't be there. And still, if you are experiencing any kind of constipation, then yes, you seek the treatment advice of a surgeon. They will advise you some kind of a laxative, increase water intake, and all such kind of the paraphernalias. You should be having all the armamentariums. Okay. All right. So here we come to the end of our session, where we have discussed about the hemorrhoids, the piles, Bawaseer, or the fissure, and also the fistulas, the Bagandar thing. So I'll be happy to answer any more further questions if they are asked recently or maybe in the near future. Okay, regarding all such things. I hope I have cleared all the doubt of yours. If ever remaining, we are here to answer. Good. I think we can close it. Yeah.
Okay. Okay. Thank you, Isha. Is there any more